Welcome to the I Spy with My MyOI podcast. I am your host, Brittany Sierra. I am a certified oral-facial myologist, registered dental hygienist, and lifelong learner. My goal with this podcast is to expand your knowledge of oral-facial myofunctional disorders and to bring you up-to-date and current literature so that together we can get to the root of the problem. You ask, we'll answer by collaborating with true pioneers and specialties associated with the myo world. Join me on this journey as we dive into the life-altering world of tethered oral tissues and airway space. Let's do this thing. Quick disclaimer, all content expressed on this podcast are the views and opinions of the speakers and is for informational purposes only. You should not rely on this information as a substitute for, nor does it replace, professional medical advice, diagnosis, or treatment. Because every person is so unique, you should always consult with your specialized healthcare professional. Patrick McKeown is the president of the Buteyko Professionals International. He is also a member of the management board and the advisory faculty of the International Academy of Breathing and Health. Patrick was educated at Trinity College Dublin and later studied in the Moscow clinic of the founder of the Buteyko breathing method, the late Professor Konstantin Buteyko. He was honored to be awarded a diploma in the Buteyko method by Professor Buteyko. Patrick's current professional affiliations include being a fellow of the Royal Society of Biology, a member of the Physiological Society, a member of the Academy of Applied Myofunctional Sciences, a fellow of the Buteyko Professionals International, and a fellow of the International Academy of Breathing and Health. From a very young age, Patrick suffered from asthma and relied on an array of medicines and inhalers until he discovered the Buteyko method at the age of 26. This life-changing discovery motivated him to change his career in order to help children and adults who suffered from similar breathing problems. Following his time in Russia in 2002, Patrick has been teaching the Buteyko method in Australia, USA, and throughout Europe. He has penned 7 books, including 3 Amazon bestsellers, and has been invited to speak at the dental and respiratory conferences throughout the world. In collaboration with the University of Limerick and Limerick University Hospital in Ireland, Patrick was the Buteyko method instructor in a clinical study investigating the Buteyko method as a treatment for individuals who had a diagnosis of asthma and chronic rhinosinusitis. As published in the leading otolaryngology journal, Clinical Otolaryngology, the results showed a 70% reduction of nasal symptoms in participants, including snoring, loss of smell, nasal congestion, and difficulty breathing through the nose. Patrick's latest book, The Oxygen Advantage, is based on his experience of working with thousands of clients and hundreds of healthcare professionals, along with his extensive research of breath hold training over the past 13 years. Patrick has been interviewed internationally for radio and television, including with Dr. Joseph Mercola, founder of the world's largest health website, Mercola.com. Good morning, Patrick. Thank you for coming on to talk with us about what you know best, which is the importance of nasal breathing, which again is so important right now, especially with everything going on with the spread of the corona disease. So if you'd like to discuss with us how important nasal breathing can be in shielding any kind of disease, really, let's just kind of get started with that.
Of course, Brittany. Yeah, it's this is controversial sometimes when I'm talking about the benefits of nasal breathing. I find it very bizarre that the World Health Organization hasn't mentioned anything about the importance of nose breathing, that governments aren't talking about it, that I understand the whole emphasis on, washing hands, etc., and keeping social distancing. But we also have to bear this in mind. Water particles in airborne air is how this virus is being spread. And if you breathe through your mouth, individuals who have the virus, mouth-breathing individuals who have the virus, there is a 42% greater water loss through the mouth than through the nose. So we have to bear in mind that individuals who are already infected, their chances of infecting other people are increased when they are breathing through an open mouth because they lose more moisture, and because the virus is carried in airborne air, in water particles, it's increasing the risk of transmission to other people. I think that's logical. That makes common sense. I don't have clinical trials showing that nasal breathing is going to help prevent COVID-19. Nobody has clinical trials because it's so new. But we have to look at the logics and the common sense of this. We look at a gas called nitric oxide. It was first discovered on the exhale breath of the human being in 1991. And this gas is reported to be produced inside the paranasal sinuses, so a group of air cavities or cavities which are surrounding the nasal cavity. Now, possibly it's also produced inside the nasal cavity. And nitric oxide has antiviral effects. So it's antibacterial, antiviral, and antimicrobial. Now, the mouth doesn't present any form of defense in terms of protecting the individual against any airborne viruses. So I put a comment on one of the social media. I wrote an article, and it's buteikoclinic.com/corona-virus. And when I put it on social media, I had some guys, evidence-based medicine, coming back to me saying, how dare you say that people should be nose breathing? And this is the kind of stuff that you face. We have to ask, where is the common sense in all of this? I was in London. I was traveling very, very frequently during, right up until last week, I came back on the 17th of March. I was in crowded places. I was in tube stations. But I did one thing. Anytime that I was face to face with other human beings, I'd breathed through my nose, but I also breathed less. Because my whole emphasis is, I want to take as little air as possible into my body during that time. Now, I understand you only need a small amount of virus for it to get into the body. And inside the body, the virus replicates itself. But there are studies that were shown in laboratories in 2005, looking at the coronavirus, the SARS, which is in the same family as COVID-19, but different strains. And when scientists isolated the SARS virus and put nitric oxide to it, it prevented the replication of the virus. So this wasn't just 2005. We also look at the work of Dr. Lundberg, Professor John Lundberg, who's professor of nitric oxide from the Karolinska Institute in Sweden. He has also spoken about the antiviral properties of nasal nitric oxide. The concentration of nitric oxide through the nose is 50 to 200 parts per billion, and the concentration through the mouth is 10 parts per billion. And what increases nitric oxide in the nose, one is slow breathing. So the slower you breathe, the lighter you breathe, the greater the concentration of nitric oxide, because it's continuously released into the nasal cavity. So if your breathing is slow, you're taking a higher concentration into the nose, and nitric oxide sterilizes the air inside the lungs. It's also a bronchodilator, and it also helps to redistribute the blood throughout the lungs. Now, why would redistribution of blood throughout the lungs be important in breathing? Well, normally as human beings, we are upright. We're either sitting as we are doing today, we are standing. And because of gravity, the greatest concentration of blood is in the lower lobes of the lungs. If we breathe through an open mouth breathing tends to ventilate the upper regions of the lungs. Mouth breathing is ventilating the upper regions of the lungs mainly, but the greatest concentration of blood where gas exchange is required to take place is in the lower regions of the lungs. When you breathe through your nose, you're more likely to take the air deeper into the lungs. And when you breathe through your nose, you're harnessing nasal nitric oxide. And as nitric oxide arrives in the air into the lungs, it redistributes the blood throughout the lungs. This way, oxygen uptake is increased. And in terms of the biological significance of nasal breathing, it increases the pressure of oxygen in the blood by between 10 and 15%. So what will I do if I'm, like many people, and I happen to get infected? Well, of course, I'm staying fairly isolated at the moment, like most people. So I'm doing everything possible to prevent it. But if I was to notice that my breathing is getting labored, what I will do is I'll start doing small breath holding to help calm down my breathing, because labored breathing will often cause bronchoconstriction. So the airways in the lungs can narrow as a result of the harder and faster breathing. The other thing that I will be doing is breathing slowly. breathing slowly and taking the air deeper into the lungs, reducing the number of breaths per minute, because every time you take a breath, you lose air to dead space. So every breath that we take into the body, 150 milliliters of that air doesn't arrive into the small air sacs in the lungs for gas exchange to take place. In order to optimize breathing efficiency, we are much better off breathing light, breathing slow, and breathing deep. Light breathing is important because, of course, light breathing is all about the biochemistry of the breath. And the biochemistry of the breath is centered on carbon dioxide. And it's not just that carbon dioxide is a waste gas. That's often what we hear. We have to bear in mind that carbon dioxide performs many very important functions in the human body. One, it's a primary regulator of blood pH. So through the breath, the body helps to maintain normal blood pH at 7.365. A second function of carbon dioxide is that it's a vasodilator. It helps to improve blood flow, improve blood circulation. For example, people with cold hands, people with cold feet, people with brain fog, oftentimes they have breathing pattern disorders. So if I shake somebody's hands, of course, we're not doing it at the moment, but if we shake somebody's hands normally, and if the person's hands are cold, it can give me an indicator that this individual does have breathing pattern disorders. Because if you are breathing hard and fast, your blood circulation is impeded, your blood flow is reduced. The third factor is that carbon dioxide is a requirement for the release of oxygen from the red blood cells to the cells. Now, it's not the only requirement, but if you were to Google the oxyhemoglobin dissociation curve, you will see that hemoglobin affinity for oxygen reduces in the presence of carbon dioxide. So in very simple terms, when we take oxygen from the lungs and that oxygen passes from the lungs into the blood, in the blood, 98% of oxygen is carried bound by hemoglobin. Only 1.5 to 2% of oxygen is dissolved directly in the plasma. So hemoglobin is a protein within the red blood cells that is carrying oxygen. How do we get hemoglobin to release oxygen to the tissues? Well, as carbon dioxide increases, blood pH drops, and hemoglobin affinity for oxygen reduces. In other words, the lighter we breathe, the more normal carbon dioxide there is in the blood, and this assists in hemoglobin releasing oxygen more readily to the tissues. So anybody with respiratory conditions, nasal breathing is absolutely vital, both during rest and also during physical exercise, both during sleep. And we may be touching on that, especially with dentists involved more and more with sleep medicine, which I think is absolutely crucial. It's the dental industry, which is the gateway to the airway. And it's only unfortunate that dentists didn't get this role earlier on. It should be that it's in identifying risk factors in both children and in adults. I think dentists are in such a superior position. They see their patients more regularly. They're looking into the mouth. They can identify these factors early on, and they can do something about it, especially with craniofacial development and growth, especially airway dentists who have a recognition and an understanding, not just in the importance of straight teeth, but also in the importance of the correct craniofacial development and a good airway. But over the years, Brittany, as well as since 2002, I worked with many people with asthma. Most of my work was from 2002 until 2008, 2010 was primarily with people with asthma. And then we started seeing people 10 years ago with sleep disorder breathing, and that was about 30% of the people coming into us, and anxiety and craniofacial development. So my main areas of focus from a health perspective: respiratory conditions, sleep disorder breathing, anxiety, panic disorder and depression, and craniofacial development in children. Now, to help people with asthma, to help them prevent their onset of chest infections, and because it can be common that with individuals with asthma, if they get a chest infection, it leads to a progression of their symptoms. Their symptoms get worse. Breath holding. And what I mean by this is taking a normal breath in through your nose, a normal breath out through your nose, pinching your nose, and walking while holding your breath. It's a stressor to the body. And it seems to be having some influence on causing the immune system to be better able to cope, to reduce the onset of chest infections. This is something that I've personally practiced myself. I speak a lot for a living. And if I have, because my background, of course, is asthma, I have scarring on my lung tissue. So my lungs are never perfect, but at the same time, it has made a tremendous difference to me in what I do. And that's how I came across this field. It was for my own personal issues. But if, for example, I was having a cold or a chest infection, I would automatically stop doing my work. And for a few minutes every hour on the hour, I would go into a room and I would take a normal breath in through my nose, a normal breath out. I would pinch my nose and I would walk holding my breath until I felt a fairly strong air hunger. Then I would let go and I would breathe in through my nose. I would wait a minute, do it again. And I would repeat it about 3 to 5 times every hour on the hour. That's how I stop chest infections. And I've seen myself having a chest infection during the day. And that night I would tape up. And even though I would have nasal congestion, because of course, inflammation in the lungs isn't just isolated to the lungs. If you have an issue with your lungs, it travels up to your nose. And if you have an issue with your nose, it travels down to the lungs. So with nasal congestion, you may need to use a nasal dilator, which is based on the Cottle maneuver to just gently prise the nostrils open to allow air flow freely into the lungs. So I would have a nasal dilator on and I would have my mouth taped and I would wake up the following morning and the chest infections would have resolved. Now, I've been doing that for many, many years. Is there any clinical evidence on it? No. We've 20 clinical trials looking at using the Buteyko method as a method to help with people with asthma. And I had 2 papers I was a co-author that were published in the American Journal of Respiratory and Critical Care Medicine in 2017. And this was looking with children with asthma. We improved all of these children's parameters. These were mouth-breathing kids with asthma. All of their asthma parameters improved. Their school absenteeism reduced, and their sleep disorders also reduced. If you have a child with inflammation of the lungs, it's not just isolated to the lungs. They are more likely to have congestion of the nose. And of course, as you will be aware, when the nose is congested, you are 1.8 times more likely to have a sleep disordered breathing. And with children, snoring is a sleep disordered breathing. And children with sleep disordered breathing, they have 10 times the risk of learning difficulties. And I remember myself going through school. For me to get grades, I would have to concentrate and I would have to work and spend so many hours studying. Because if your concentration is not optimal, you don't have retention, your memory is affected, and you don't have the capacity to hold your attention on the subject matter. And as a result, it impedes and it negatively influences your learning ability. We are grading these children as being intelligent based on their academic ability. But nobody, or very few people, are talking about the importance of quality sleep for these kids. We are putting labels on these kids who are underperforming in school, who may have ADHD, attention deficit hyperactivity disorder, and we are not considering in the main the impact that sleep quality is having on these kids. But I'll stop talking in a moment, by the way, and I'll let you get an area.
So informative.
But it's not just about that. We have to look at papers. Dr. Christian Guilleminault published a paper, and the paper was looking at young infants who died as a result of sudden infant death syndrome. And the name of the paper, it was published in the European Journal of Pediatrics in April of 2012. The title of the paper is Death, Nasomaxillary Complex and Sleep in Young Children. Now, this is a dreadful paper. And this is a dreadful paper from the point of view any parent having to deal with the death of a young child. They looked at 7 children who had passed as a result. They passed abruptly in their sleep. They had abrupt deaths. And they looked at their health status, their sleep history, the death scene report, etc., and autopsy. 2 deaths, history revealed presence of chronic indicators of abnormal sleep in all cases prior to death. All children who died with sudden infant death syndrome, they all had abnormal sleep. And they had a history of often an acute, but often mild rhinitis, a stuffy nose, just preceding death in several. 4 children, including 3 infants, were usually sleeping in a prone position. An autopsy revealed that there were features consistent with a narrow, small nasomaxillary complex, with or without mandibular retroposition. This is a case of life and death. We know that the human face is getting smaller. We know the risk of tongue tie, pacifier use, lack of breastfeeding, eating pre-chewed food, not exercising our jaws to develop the jaws for good craniofacial development, mouth breathing, poor tongue resting posture. And, whether the child is born genetically with a narrow maxilla and a high palate, or whether environmental factors and habits have caused it, it does not matter. The issue is that if a child has a high, narrow palate, it needs to be addressed. And dentists are in a wonderful position to do it. But the dental industry has been debating this for 100 years, 111 years and more. If you look at a journal that was published back in the 1900s called Dental Cosmos, and there's a paper published in that looking at malocclusion in children. And it talks of these children being unattentive in school. They have flattened facial features. The child accuses them of daydreaming. They don't have the capacity, their sleep is impacted. The same features that we are discussing today in children was evident 100 years ago, but academics have debated it for 100 years and did very, very little about it, because the debate about science is they are looking for questions such as, how long does the child have rhinitis before it causes craniofacial abnormalities? Is the craniofacial abnormality as a result of genetics or as a result of environmental and different factors? At what age does rhinitis have to occur before craniofacial abnormalities take place? They are looking to answer questions from an academic point of view, and they are not looking at the common sense and the logics of addressing the problem in the first instance. So sometimes in our quest for evidence-based medicine, it's at the expense of millions of children who are suffering unnecessarily because academics and egos are too involved and not thinking about simple things that we can introduce here. And I know I'm giving out simple things that we can introduce to help these children with no side effects. There is no side effects teaching children to breathe through their nose. And I've spoken with professors of medicine, and they will tell me that there is no difference between mouth breathing and nose breathing. Oh my God, what planet are these guys on? Because if you were to open up any medical textbook, you will never see a function of the mouth is never listed as breathing. The nose is the primary and physiological mode of breathing in the human being, regardless of age. And it's time to get back to basics. And it's time to put the ego aside. It's time to get these guys off their pillars and start looking at the effect and the impact and the negligence that not focusing on the impact of oral breathing in children. Right. It's a travesty.
It's almost like, what percent, it's like these children have to suffer to a certain percent before anything's going to be done. I mean, yes. No child should be suffering. There's just no reason for it.
Totally, Brittany. And, this is not new information. Right. Like, dentists have been knowing about this, some dentists, since 1909. And, we know, and I will say that dentists are more progressive in this field than doctors, medical doctors. We have so many dentists who are aware of airway, and they're doing a tremendous job there. And I think, I'm in a position to talk because I don't have a dental license. So I can look and tease out this information and I can put it out there. And if people challenging me, well, the weight of evidence, of course, the whole debate is the child mouth breathing because of high narrow palate, or is it the high narrow palate that's causing mouth breathing, or is it the mouth breathing that's causing the high narrow palate? Again, it doesn't matter.
Right.
The issue is that there's a high narrow palate. So I'm currently writing a new book, and I'm really putting an emphasis on the importance of the dental community here, because I think the dental community, the establishment, the associations, I think they've been asleep behind the wheel. They have failed, and they haven't been driving this. And I'll just give you another one, Brittany, before I go on. The efficacy of adenoidectomy and tonsillectomy was first uncovered in 2010. And despite this procedure being carried out in children for decades, in 2010, a study of 587 children who had adenoidectomy and tonsillectomy, the sleep apnea was only resolved completely in 27% of these cases. 73% of these children out of 587 children continue to have unresolved sleep apnea post-adenoidectomy and tonsillectomy. Now, granted, their AHI did significantly drop, but at the same time, there was residual sleep apnea in 73% of cases. Now, it's not just about the adenoids, it's about the airway, because enlarged adenoids themselves are a problem when the airway is compromised. If you have a child with a really well-developed airway, if that child develops enlarged adenoids, they are still likely to be able to breathe comfortably through their nose. And nasal breathing, the filtration of the air, the moistening, the carrying of nasal nitric oxide, which is a natural anti-inflammatory, will help to resolve the enlarged adenoids. The real issue is the kids with the compromised airway, with retrognathia, with high palate, with narrow jaws. They have a compromised airway, and when you combine a compromised airway with enlarged adenoids, then you have a problem. But it's not just enough to remove the adenoids. The real issue here is the airway, because if the airway was adequate in the first instance, enlarged adenoids wouldn't be a problem. And if we just remove the adenoids and remove the tonsils, Dr. Christian Guilleminot's papers showed that there's a worsening in the AHI index, that there's a 65% relapse within 3 years unless nasal breathing is restored. Now, if you look at, the ear, nose and throat doctors in the main, now there are some brilliant ones who know about this and who do encourage breathing rehabilitation post-surgery, but the vast majority of ear, nose and throat doctors don't. They carry out the procedure, they get paid for it, and there's no follow-up post-tonsillectomy and adenoidectomy. These children continue to mouth breathe following the procedure, and they will develop sleep apnea. It's just a matter of time. And I would give you as my example, and that's why I get very frustrated with this. I had a nasal surgery on my nose in 1994 because of chronic nasal obstruction and chronic sleep problems. And I, as a teenager, I was told when I stayed, I went to a university in Dublin, Trinity College in Dublin, and part of that year we did an exchange, an Erasmus program with a university in Uppsala in Sweden. So I stayed there for 1 year. And I was sharing dorms, student dorms. And the students were telling me that I was stopping breathing in my sleep. And they thought that I was dying. That's what they were saying. And of course, I had no idea that this was obstructive sleep apnea. I only then realized, okay, I had a sleep problem 20 years, afterwards. But my point here is nobody ever told me to breathe through my nose. And when I got my nose fixed in 1994, when I came out of the surgery, I still didn't use my nose to breathe. The obstruction was addressed, but the habit of oral breathing wasn't. And when we have children coming in, I'm often wondering, why are they breathing through an open mouth? Is it a habit? Because if it's a habit, we need to address it. Is it obstruction of the nose? And if it is, we also need to address it. But where is the obstruction? Because if it's rhinitis, we can help resolve rhinitis by doing the breathing exercises. The wonderful thing about breathing through the nose is breath holding will decongest your nose, whether you're a child or an adult. Don't do breath holding though if you're pregnant, if you have any cardiovascular issues, if you have obstructive sleep apnea, never do strong breath holding. You have to be in reasonably good health to do it. But most kids can do strong breath holding with no side effects. Now, I know that Dr. David McIntosh, he was saying, don't teach breathing re-education to children. He's an ear, nose and throat doctor, and he's often on airway groups. And he said the reason being is because children have pulmonary hypertension. I said, okay, this is interesting. I've worked with many thousand children since 2002. I've only seen 2 kids since 2002 presenting with pulmonary hypertension. So I said, what's the risk here? So I started looking at the research. It's something like 1 child in 1 million children.
Oh, wow.
Whether it's in the Netherlands, whether it's in the UK, whether it was in Spain. I don't have USA studies. But here we have a situation that the risk was minimal. And of course, if the child is presenting with pulmonary hypertension, don't do strong breath holding. But other than that, if the child is epilepsy, of course, don't do strong breath holding. But with most children, it's relatively safe. We can open up the nose. And once you establish nasal breathing, the nose works better. And that's really the key here is we use the nose and our nose works better. But most children or adults, if they try breathing through the nose, if they experience air hunger, they don't continue breathing through the nose because they don't like the feeling of suffocation. So they switch to mouth breathing. So what's causing mouth breathing is a feeling of air hunger. And what's causing air hunger is nasal congestion, breathing pattern disorders, obstruction of the nose, or a small nose. Anatomically, if children or adults if they have a small nose anatomically, in one study, 97% of people, children, adults with a small nose were oral breathers. And in that same study, only 12% of individuals with an adequate nose were mouth breathers. So I'll repeat that. I think I got it mixed up. In that study, 97% of individuals with a small nose were oral breathers. They were mouth breathers. In the same study, 12% of individuals with an adequate nasal airway, they were mouth breathers. So we have to wonder the size of the nasal airway, but also breathing pattern, because if you were breathing fast and upper chest breathing, that is a breathing pattern disorder. When you try to breathe through your nose, you're feeling you're not getting enough air, and that's going to cause the shift to mouth breathing. And mouth breathing is fast and shallow breathing. If we want to achieve nasal and diaphragmatic breathing and slow breathing, the 3 go together, and the foundation